Hi, good morning. My name is Alexander Postalian. I am a cardiologist here at THI, and I do vascular and also structural intervention. And I wanted to take a few minutes to discuss the story of a patient that was very impactful for me and our team here, and it also highlights the team-based approach that we have here at the Texas Heart Institute. He's a 59-year-old man who had an aortic valve replacement about 15 years prior to presenting to our hospital. He has rheumatoid arthritis and some sort of inflammatory lung disease that wasn't well characterized, but he was on home oxygen intermittently at home, no more than 2 liters. He started having worsening shortness of breath that started about 3 weeks prior to coming, but it was much worse over the last couple of days. And he also had an episode of fever the day before he came to the hospital. He went first to an outside facility. They did an ultrasound of the heart that was read as moderate aortic insufficiency and a dilated ascending aorta. They gave him antibiotics and they initiated a routine transfer because he was reportedly clinically stable and the patient wanted to be transferred to our facility. But when he got to the hospital, I could see that he was sitting on the side of the bed, breathing hard, and he looked quite distressed. I looked at the images of the outside hospital, and I suspect that his aortic regurgitation could have been a little bit worse than was initially suspected, but we did a study here, and this is what it showed. On the left side of the screen, you see there's something kind of flopping in and out the LV outflow tract. And on the right side, you see the color signal that is not easy to see, but based on the degree of turbulence and the color distribution, you can suspect that this is severe aortic regurgitation. This is a short axis view, same thing on the right side, lots of turbulence, suspicious for severe aortic insufficiency. Now, if this were a live discussion, I would love to hear your thoughts, and I guess we'll talk about those during our panel discussion, but what would you do next? And at this point, the discussion centered around doing a transcatheter valve replacement or open surgery. However, the transcatheter replacement was an issue because the valve may be infected, and that is a contraindication for the transcatheter-based approach. The surgeon initially, we had a discussion, and he said, hey, I think this guy is too high risk to have another surgery, so if you can do a transcatheter, that would be great. So what we did is we activated our multidisciplinary committee to come and urgently discuss the case. We all get together and have a conversation either live or remotely. However, before we did that, the patient decompensated, and we had to put him on VA ECMO, which is cardiopulmonary bypass, emergently. We stabilized him. We had the discussion, and what the decision was made to do a transesophageal echo to look at the valve in greater detail before we made a final decision. And this is that. This is a short axis of the aortic valve. And you can see on the left, there is something flopping at the level of the valve, suggestive of structural degeneration, possibly vegetation. And on the right, you can see that this is severe aortic regurgitation. And you can confirm that on the long axis view, something going in and out of the LVOT. Now that we know this, what do we do? Well, the suspicion for endocarditis was high enough based on the fact that he had a fever and the image appearance. So the decision was made to bite the bullet, do what is necessary, and take him to the OR. The next day, he went to the OR, the next morning after the ECMO, and he had an aortic valve replacement with a bioprosthetic valve, an ascending aorta replacement for the aneurysm that he had with a 30 millimeter graft. The surgeon told me that, hey, his lungs look pretty stiff during the operation, and this might be a problem weaning him off oxygen. So we made note of that. It was a long, hard surgery, but it was successful. He stayed on cardiopulmonary bypass after the surgery, and we were unable to take him off the oxygenator. Once his heart recovered, it was pumping well, we switched him from VA ECMO to VV ECMO to only bypass the lungs. This was approximately 1 week after the surgery. 1 day goes by after the VV ECMO change, cannot win him off. 1 week goes by, cannot wean him off. 1 month goes by, we cannot wean him off. This is his chest x-ray when he was as dry as possible on the VV ECMO machine, and you can see there's clearly opacities on both lungs, suggestive of a significant issue. What now? You have this patient on bypass, just had a major high-risk surgery that he made it through, he's young, and we cannot take him off the lung bypass machine. This was not an easy decision, but we bite the bullet again, we do what is necessary again, and we plan for a lung transplant, which is not an easy task. We called the lung transplant team and started the workup for the transplantation that takes quite a while. In the meantime, this patient is hooked up to a lot of machines, and thanks to the immense dedication of the team that was taking care of him and also the will of the patient and his family, he had a lot of physical therapy. He could ambulate with the assistance of a portable oxygenator. By the way, it's called the Breathe machine by Abiomed. Not that I'm doing a commercial for the company, but it worked very well for this patient. And eventually, he had a right lung transplant. And I say a couple of false alarms because a few times we thought we might be getting a lung, but it was not a good match. So we moved on, but eventually he got the lung. He was removed from the VV ECMO 3 days later. And he was on ECMO for a total of 97 days, which is a long time to be on ECMO. He was discharged. He had a readmission for a small problem, but now he's living his life together with his wife and family. I see him in clinic, and he's doing great. He's living his life. And this might sound cliched, but honestly, he changed my life. It can sometimes be hard after you're doing what we do for a period of time. You can sometimes become numb to patient outcomes, to bad outcomes. And maybe hope is not as strong as it once was at the beginning of training. But seeing him walking into his room, seeing the pictures of his family, seeing him fighting for his life, seeing his family sitting at the side of his bed every morning, and witnessing the outstanding work by the entire team involved with nurses and physicians, getting a major heart surgery, super high risk, having him on ECMO for so many days, and then doing an unplanned lung transplantation, and him making it out of there and living a normal life was really life-changing for me. And I thank him a lot for that. And I also thank you guys for listening to me. This is my email. If you have any questions, comments, or concerns, please feel free to contact me. And again, thank you very much.